Hello and welcome to Ask the Experts. I'm Claudia Otero. Today we are going to be speaking with urologist Dr. Ryan Griggs. Dr. Griggs joined Salinas Valley Health in 2022. He is a board-eligible physician and surgeon who specializes in neurological disorders and in improving patients' health and happiness when it comes to sexual function and male urinary incontinence. Dr. Griggs, thank you so much for being here today.
My pleasure. Thanks so much for having me.
Of course. And can you please tell us a little bit about some of the disorders that you treat and what specifically you specialize in?
Sure. So I actually specialize in all avenues of men's health. And what that encompasses is erectile dysfunction, ejaculatory disorders, enlargement of the prostate, male urinary incontinence, overactive bladder, curvature of the penis, testosterone replacement, and sometimes counseling, to be honest.
You also wear that hat.
Yeah.
Okay. I think you mentioned it too, but enlargement of the prostate?
Yeah. Yeah. So enlargement of the prostate is basically the prostate is a circumferential organ, unfortunately for males, but the prostate can enlarge widthwise outside or in towards the urethra. And you can have a big prostate or a small prostate. It really has no bearing on symptoms. That's been studied because you can have a large prostate, no symptoms, and vice versa. But if you have a prostate that's impinging on your urethra, it's tough to empty your bladder. You have a weak stream. You feel like your stream starts and stops. You may feel like your bladder's not empty. So we help try to mitigate those symptoms with medications and eventually surgery if needed.
And that's important for our audience to know in case they are having those types of issues. So thank you for expanding on that.
Pleasure.
Well, today we're going to be discussing urinary incontinence and urological prosthetics. What causes urinary incontinence in men, and how do you treat this problem?
So in men, it's really broken down into two different categories. One, overactive bladder. Two, or post-prostatectomy or stress urinary incontinence, because normally stress urinary incontinence doesn't happen in males unless they have some type of procedure. So post-procedural stress urinary incontinence for men. And so we kind of divvy up our individual patients in that way. If they come in, they say, I'm leaking urine, the first question I ask is, is this because you can't make it to the restroom on time, or is this because you're cough, sneezing, laughing, get out of the car, and then all of a sudden you feel leakage on yourself? And just in that question, I'm able to put in a patient into a niche in a treatment pathway.
Okay. Do you want to talk a little bit about what those treatments are?
Sure. So we'll start with overactive bladder. It's a little bit more involved because it's kind of sometimes a multimodal approach. You usually start with behavioral modifications, and these are things that you typically avoid. So anything that irritates your bladder, this is going to be chocolate, spicy food, carbonated beverages, and that includes mineral water, by the way, sodas, teas, coffee, alcohol. So basically, avoid the pleasures in life. But that's the most lasting effect, because otherwise you force yourself to take a medication that has side effects. Sure, you'll have a headache for a day or two after stopping drinking coffee or something like that, but the lasting effect of not irritating your bladder works really well. So behavioral modifications is number one. Sometimes you can employ pelvic floor physical therapy, which is where you go to a physical therapist and they teach you breathing exercises and bladder holding strategies to reduce the irritation of your bladder to go less frequently. And then you go on to a medication, and that's really up to a patient, because do I want to take a medicine or do I want to make a behavioral change? And if they accept the risks of taking medication, then sometimes medications are the first line for patients, because I don't want to deal with stopping the things that I enjoy or cocktail hour at 6 o'clock every night, right? And so I kind of curtail that to the patient's desire. And once one medication fails, and by the way, that's defined as a 4 to 6 week treatment cycle. You can't take it one time, oh, this isn't working. So 4 to 6 weeks, if you fail one medication, you can try another.
I see.
And if you try another and that doesn't work, sometimes you can combine them. So those are the first two treatment tiers, 4 in all. The third treatment tier is basically somebody who's frustrated, where they've failed multiple medications, they failed conservative therapy with behavioral modifications, and now they're on to wanting to do a procedure. And these procedures are very short, office-based mostly, except for one of them. The three modalities are one, peripheral tibial nerve stimulation, that's PTNS. For lack of a better term, they put a acupuncture needle on your middle ankle, and they impulse electrical energy that stimulates that nerve that transmits information to the bladder to tell it to quiet down.
That's
I don't
fascinating.
I don't offer it to a lot of people because it's a little bit arduous for a schedule. It's a once weekly, and there's not a lot of patients that can come to the doctor on a weekly basis. You may find that hard to believe, but it's kind of hard to see the doctor on a weekly basis. And then that's done for 12 weeks, and then monthly maintenance after that. The second one is bladder Botox. So Botox for the skin, we'd use Botox for the bladder. I also use it for the scrotum, Scrotox. So I'll just do a little ad lib on that. But basically, the paralytic Botox is injected into multiple areas of the bladder. That paralyzes the bladder, allows you to hold more urine, and decreases urinary frequency and urgency. There's caveats to that treatment, of course, anything that you do.
Right.
There's a 10% risk of urinary tract infection. There's a 6% risk that you're going to have to catheterize yourself after the procedure. So I always counsel patients, if you want to try this, unfortunately, you're going to have to agree to catheterize yourself in the event that that may happen. And my partner, for example, said it's maybe happened once or twice in his entire career, which spans several decades, by the way, but that's the statistic is 6% with that. And then the third one is a surgical procedure outpatient where basically a pacemaker is implanted right over your buttock on either side. And that pacemaker is a pacemaker for the bladder instead of the heart, and it consistently transmits electrical signals to the bladder to quiet it down. And that's done through a lead that's implanted through your sacrum.
I see. And what is that procedure called?
That's called sacral neuromodulation.
Okay.
And I do not do that procedure. However, I have a colleague that does, and I usually refer my patients over to Dr. Cantor to complete that procedure. The fourth line, almost nobody does it because it's very invasive. The fourth line is removing or augmenting the bladder, and augmenting the bladder means you're adding to it, right? So what they would do is either they remove the bladder and then they make a conduit, which is a piece of bowel that they take from your intestines, and then they bring it out to the anterior abdominal wall, and then urine spews out into a bag.
I see.
Quality of life severely diminished, I would say, correct? The other way is bladder augmentation, where they similarly take a piece of bowel and they clamshell the bladder open. So instead of it being a spherical, they make a longitudinal cut on the top, bivalve it like a clam would open, and then they onlay the bowel onto that surface, increasing the bladder capacity.
So for those two procedures that you just mentioned, I mean, who would be a candidate for something like that? I mean, it sounds very severe.
I've only had one since I've been here, albeit 6 months, but there's only one person who's failed everything. It would be basically anybody who's failed all of those tiers that we've just talked about, 1 through 3.
Okay. And is there an age limit to that? I mean, or for any of these procedures?
There's no age limit per se. It's more of a functional status, I would say. There's other things you have to take into effect. Body habitus, which is how a person overall appears. Do they have multiple surgeries in the past? Say somebody has had their uterus removed and their gallbladder removed and their appendix removed, and then later they had some bowel surgery, and then later they had a puncture wound, and you see all of these scars on their belly. That would be a poor surgical candidate because there's going to be an immense amount of scar tissue, and that would be difficult to open and heal. Similarly, somebody who has a very large habitus who might need to consider weight loss surgery before they even have surgery because of the massive tissue layers that you have to go through.
What about somebody with a chronic disease like cancer?
That's kind of a hard discussion with the patient because cancer would need to be mitigated before you would undertake that procedure. Because I would hate, I don't do the procedure, but I would hate to refer them to somebody and their cancer isn't treated and then it spreads because they've opened up the cavity to go somewhere else.
I see. Okay. So that's a very important point, I think, is to have that conversation with your spouse, your partner, obviously your oncologist or your primary care physician, and
yeah, but as I said, I mean, almost nobody does that. I mean, that's very rare to do. And I don't typically present that to my patients when I'm counseling them about overactive bladder. It's usually the end of the conversation where they've been in my office several weeks and months, and they're really distraught, and their quality of life is so diminished that they're willing to undertake a large surgery, and I refer them to a reconstructive center for that.
How much time does it take for you to perform some of these procedures that you just mentioned?
Yeah, so as I said, all of them are in the office except for the one, and Botox takes approximately 15 minutes. could be less sometimes. It's a little bit more difficult in a male than a female because of the length of the urethra, but about 15 minutes for that. And then PTNS, as I said, that's once a week for about 30 minutes.
So let's talk about male stress urinary incontinence. Can you talk a little bit about that and how you treat this issue?
Yeah, and I think I mentioned before, it's usually caused by a post-procedural thing that a male's had, prostatectomy for prostate cancer, or carving down the prostate for urinary frequency, weak stream, intermittent stream, and things like that to open the urethra so you can pee easier. Sometimes the sphincter that keeps you continent as a male can be damaged during those surgeries because, as you can imagine, the male urethra, or the female urethra for that matter, isn't meant to have things go backwards. It's meant to go forwards, right? Mm-hmm. Urine's supposed to come out, nothing's supposed to go in, and anything that you insert in causes trauma. And so that is definitely a risk with any procedure you have. And basically what happens is the sphincter is either damaged by procedure, or it can be damaged by other things. It can be damaged by neurological disease, spinal cord injury, and things like that can happen, where the sphincter is just incompetent. You go in with a scope and you ask the patient to cut their stream off like they had to go to the bathroom and had to hold it. They contract their pelvic muscles, and you can actually see the urethra just stay exactly like this. In a normal urethra, you would see the external sphincter coapt and come down and close the urine channel off. So these patients are really only managed surgically or conservatively, two different pathways. And the conservative is upfront for everybody. Mm-hmm. That consists of either diapers and or pads, a Cunningham clamp, which is, for lack of a better term, a clothespin for the penis. It's padded for more comfort, of course. There's a Texas catheter. That's the colloquial term for an external urethral catheter, where a silicone condom goes over the penis, and then that's connected to a tube that goes to a leg bag, so nobody even needs to know really that you have a catheter bag. And Kegel exercises, which you may not think about for males. It's really traditionally for females. But what males don't have to do their entire life after they have a child or something like that is condition their pelvic muscles, because they have a prostate and a sphincter, so they have two ways to keep urine from coming out. But as soon as you damage that, then they have to rely on their alternative mechanisms, which is their pelvic floor muscles, to try and bring them together under periods of stress. So typically it's with pelvic floor physical therapy, where they work on strengthening exercises of your pelvic muscles. And you do that for increasing time lengths and increasing frequency. And the key is you're exercising a muscle. So you exercise the muscle, you get strong, and you're going to the gym all the time. And oh man, I'm not tired anymore. Mm-hmm. You know, I'm not having stress urinary incontinence anymore. I feel great. And then you stop doing it, the muscle goes away, and you can be right back where you started. Okay. So that's for everybody up front. And 6 months is really the time for that. 6 months either after the procedure for a prostatectomy. It's usually 6 months to a year. 6 months after a prostate carving procedure, for example. And at that 6 month time period, have they failed that? And what the failure is their quality of life. Right. Is their quality of life diminished to the point where they'd want to do something about it? Because everything is surgical.
Right, where they're having a difficult time at work, where they're having to change their pads every couple of hours.
Right.
Or
and that can be expensive. I mean, I don't know about you, but inflation gets everything, right? Diapers, I mean, they're very expensive, and some people even put two on top of each other. Wow. So you ask somebody how many pads a day they're wearing, and I changed my pads 5 times, but they're wearing 2 pads at one time, so it's like 10. Right. You know, oh my God. And then so the patients who are deemed not surgical candidates, so those would be patients who have severe morbid obesity, patients who have had extensive radiation for cancer treatment, for example. There's a lot of scar tissue. They've had urethral erosion in the past from other devices, for example, penile implants or other devices that have been implanted that they've had in other countries, for example. Also, any of these people who are really averse to surgery, right? I think you mentioned to me before we even started chatting that some people have this extreme pelvic surgery to remove their bladder or their prostate because they have cancer in it, and then, man, do I really want to go through another procedure? Is it really worth it? And that's the question that I have to pose to them. And I always ask about their quality of life. I tell them I'm a quality of life surgeon. So if you're bothered enough to do something about it, I'm there to help you with it. And surgically speaking, that's done with a sling or a sphincter. So 2 different flavors. And it's really based upon how many pads per day that they use. A sling is a mesh implant that's used, and it's implanted through the perineum. Now everybody knows what the perineum is, but you hear it on the Jardiance commercials and things like that for diabetes. You're like, oh, there's an increased risk of soft tissue infection between the area between your scrotum and your anus. I've heard that a few times, right? I'm sure you have too. And basically, that's that area of skin right between, in males, the scrotum or the vagina, and females, and the anus. And that soft tissue region is relatively insensate. There's not a lot of pain associated with a surgical incision with that. And that's why they warn you about that, is because you don't really feel it. And then once you do feel it, it's really bad. And so you implant the mesh through that single incision in that area, and then that's tacked to the urethra. And then the arms of the sling that keep it in place are followed through with surgical trocars that go through the holes in the pelvis. So the anchorage on the urethra and the anchoring arms that go through the pelvis help elevate the urethra in times of stress. So stress being getting out of the car, coughing, sneezing, laughing, weightlifting, etc. And I had mentioned—
Working, depending on what kind of work you do.
Sure. I mean, if you're working in a supermarket, or you're working out in the field, or if you're, at a desk job and you have no urinary incontinence when you're sitting down, but all of a sudden you get up and your pants are wet. It could be anybody really with that. If you are 0 to 5 pads per day, usually a sling is what we recommend. If you are greater than 5 pads per day, or you failed other incontinence procedures, i.e. a sling, then a sphincter is really what's deemed necessary for you, because it basically replaces the sphincter that I told you that couldn't close anymore. It's an artificial device. And that's also, not always, but also in my case, I put it through a single incision where most people do 2 incisions. And I think that's kind of what separates me from the training where I did a 1-year fellowship in this compared to somebody who does it right out of residency, because most physicians are trained to do an abdominal incision, to put the pressure regulating balloon, which is one of the components of the device, in through their incision in the abdomen, and then they tunnel that down into the scrotum to the pump and put the cuff around the urethra. To put the cuff around the urethra, you need to incise where we talked about that area between the scrotum and the anus. And the way I do it is a single incision in the perineum, and I tunnel up as opposed to tunneling down, and that saves morbidity in the patient because you only have 1 incision to heal instead of 2. It also affords the patient a little bit easier access to the device because I had mentioned there's a pump, right? And sometimes patients can have a hard time getting to that pump, reaching down. Say maybe they have a very large pannus and they can't reach down there. Most of the pumps are placed pump down, whereas I place the pump up. So you have about an inch difference that can help some patients out with that.
That's fascinating.
Yeah.
Interesting. Thank you for sharing that with
Sure.
us. And was there anything else that you wanted to mention about the surgical management or the sphincter in this case?
I don't think so.
Okay.
Yeah, I mean, the contraindications to that surgery are numerous, and I'd really save that for an hour-long conversation when I talk to the patient about why we wouldn't do it in this. For example, I had an 85-year-old who had 5 devices, and I was his 8th urologist that he saw.
Oh my goodness.
And his last device was explanted because he could no longer operate the device because he had dementia.
Oh goodness.
That would be a contraindication to the device. If you do not have either one, the manual dexterity to do so, because maybe you have Parkinson's disease or you have severe rheumatoid arthritis, or the cognitive delay.
Wow.
Because
Okay.
it's life-threatening if you can't operate.
How long does it take you to perform those types of surgeries?
The sling is a little bit more complex to do because, as I mentioned, you have these trocars that you have to weave in through the holes of the pelvis, and that's done by anatomical landmarks and blind. So it takes about an hour and a half to 2 hours with that. Plus, you have to sew it onto the urethra. The sphincter takes about an hour to an hour and a half.
Okay. And patient, I believe, still gets to go home later that day,
Yes.
which is fascinating, I
Yeah.
think.
I mean, that's the way I was taught to do it, and That's the way I continue to do it.
You continue to do that. That's good.
Yeah.
Okay. After the patient has gone through either one of those surgeries, and are they in pain afterwards, or what's the scale?
It's hard to say, I would say, for every single person as a blanket statement. But I would say the vast majority of people have very little pain. But anytime you have a surgery, I always tell patients you're having surgery, so do not expect to have zero pain. If you do, wonderful. And if you have an undersold and over-delivered surgery, I think the outcomes are better from a patient perspective. So I say, oh, well, you can expect some pain, and then they don't, then they're pleasantly surprised, right? So I would say patients with a sling or a sphincter, as I mentioned, that area is pretty insensate. So they usually have mild to moderate pain, maybe 1 to 3, plus we use medications and nerve blocks to help extend those and make it more comfortable for them.
Okay. So that's really important information, I think, because some men out there may be holding off on coming to see you because they're thinking about the pain that they may experience after one of these procedures.
Sure.
So there are, and we kind of talked a little bit about this earlier, but there are men out there who are diagnosed with prostate cancer, unfortunately, all the time. Some of these men may have undergone prostate removal surgery, and in some cases, they developed urinary incontinence. What do you say as a physician, as a man, to other men out there who are in that same situation?
Well, in that situation, as we talked about earlier, I think what the important thing is to know is his cancer controlled? And if it's progressing, then the answer is you're really not a surgical candidate for that. But if the cancer is deemed to be controlled, no evidence of recurrence, then that's something that I approach in kind of a ginger fashion with the patient. I make sure that I speak with them about my expertise, how many I've done, how I do it, and I think most patients are really relieved when they hear it's through a single incision, and you don't have to incise the abdominal cavity, because that's really where a lot of complications happen, because you had your prostate surgery through the abdomen, right? You have now typically 5 ports plus a larger in the center where they extract the gland. And even though it looks minimally invasive on the outside, it's maximally invasive inside, right? I mean, you have to disconnect the prostate from the bladder, and you have to sew the bladder to the urethra. I mean, it's not a small surgery. And since I don't even enter that cavity through a separate incision, I don't need to worry about bowel being there or something that would be a devastating complication. And we use no instruments that are sharp. I literally use my finger, and my finger cannot puncture through bowel.
Fascinating. Trying to picture this as you're explaining it. Thank you for that visual.
Sure.
Well, I appreciate you talking about that, and I think it can be very helpful to a lot of people out there, a lot of men who are currently living with that situation. So I do want to change topics here and talk about erectile dysfunction.
It's
ED.
my favorite, by the way.
It's your favorite topic. We're going to see why in just a moment here.
I'm guilty. You might see my face light up a little bit.
Just a little bit.
Yeah.
Okay, so I guess the first question would be, what causes ED?
There are so many causes of ED. I mean, one of my colleagues, Dr. Mulhall, said that epinephrine is one of the most potent erectile inhibitors on this earth that we know about.
And what is that used for?
And that basically is used to artificially elevate someone's blood pressure, and it is secreted in our bodies in the fight or flight response, right? Because we're concentrating on getting away from the dinosaur that's going to eat us versus procreating. And so that kind of segues into what causes erectile dysfunction. There's psychological factors. A very large amount of erectile dysfunction is psychologically induced. And you may have a physical symptom, but then you have psychological distress, and it's a rotating cycle that's completely negative, because you start seeing your penis not work, and then you worry about it not working the next time. And then the next time, you're worrying about it working this time. And then stress, so cortisol and epinephrine get secreted, and your penis does not work, unfortunately. And then that just kind of perseverates that effect going on. So anxiety, depression, hormonal issues. So for example, low testosterone. It's one of the more common symptoms that you have with low testosterone. I would say if you have mild dysfunction, it can make a difference. If you are considering surgery or you failed pills before, it's probably not going to make that much of a difference. Diabetes, vascular disease, And I say vascular disease, that could be arterial or venous, okay? Neurological disorder, spinal cord injury, there's certainly a lot of causes.
Okay. And how do you treat it?
So I treat the patient. I don't treat erectile dysfunction because I tailor each treatment of erectile dysfunction to the patient. So either the patient is extremely motivated and says, this is what I want to do, this is how many times I want to have sex per month, and I actually ask each patient. One, the first question is, do they have a partner that's willing? That's very important. Two, is that partner willing? And in the elderly ages, that's a very important question, because if you don't have a partner that has a good relationship or willing, then it's kind of hard to treat erectile dysfunction, because then you're kind of perpetuating something that one individual wants but the other doesn't. And that's why I think it's really important to actually have the partner in the room, because I can talk to the partner and see what their kind of view is on the disorder, and if they want to treat it, and I'm happy to do exactly what they'd like to do. Some patients choose an escalating fashion where, I just want to do lifestyle changes, and lifestyle changes are diet and exercise. Nobody likes to hear that, right? But it's actually very true. If you have very mild dysfunction, 1 in 2 people, staggering statistic, okay? 1 in 2 people over the age of 40 will have some degree of erectile dysfunction. Maybe your penis isn't 100% rigid, maybe it's only 90. Maybe you have trouble making it to orgasm or something like that. But 1 in 2, that's like, I got a buddy sitting right next to me, 1 in 2.
We'll meet
So
that
one of
buddy
us
in
is
just
gonna
a
have it,
moment
you know
here.
what I mean? So I tell patients that too, and that kind of gets them thinking. We ask about rigidity, so how hard, 0 to 100%, right? How hard does your penis get? And if it's not 100%, I'm here to help you get it to 100%. Whether it be pills, starting with pills, and if you fail pills, you can go to a vacuum, or you can start with a vacuum. And if you fail either one of those, then you go to injections. And if you fail injections, then you go to a surgically implanted device, which we'll talk about shortly. And then there are extremely motivated patients, and I ask, how many times a month do you want to have sex? And if the guy says 3 times a day, I said, well, let's party. Let's do this right away. And I kind of curtail them towards a device, because those type of motivated individuals aren't going to want to wait 1 to 3 hours for a pill to take effect, or inject their penis and wait 15 to 20 minutes, and because it ruins the mood, the spontaneity, and the device really gives you the spontaneity and the rigidity that most closely emulates back when you were younger. And I think that's what people are thirsty for.
Having that youth back. Let's talk about those implants. Can you briefly discuss what they are?
Yeah, so 2 different implants. They come in 2 different flavors. There's a malleable device. Malleable means that you can bend it, okay? Very simple device. And then there's an inflatable device, which consists of multiple components, much like the urinary sphincter that we talked about. It has 3 components. It has a reservoir that's implanted in the pelvis. It has a pump in the scrotum. It can look like a 3rd testicle, but a little bit smaller. And depending on where you put that, you may see it more than others. And then there's 2 fluid-filled cylinders in the penis. And a common misconception in patients is that this is like a Reebok pump shoe, where you're pumping up the device and air is going into there, and it's actually fluid instead of air. And it's innate saline, so even if it leaks for whatever reason in the future, and we can talk about device failure in the future, but even if it fails, there's no harm in the fluid leaking out, because it's just salt water.
I see.
The malleable device is a much simpler device, where it consists of 2 cylinders that are semi-rigid. So another term for the device is semi-rigid or malleable. And when the patient wants to activate the device, they simply bend the device up in the position of erect penis, and when they're done having sex, the device goes down. And I said, when they're done having sex, right? It's no longer when I orgasm, I'm done. It's as long as the patient wants. And that's why the satisfaction is so high with these devices, with the patient and the partner, not just the person having the device. Greater than 90% have satisfaction with this surgery that's done in an hour, and you go home the same day. The second penile prosthesis, the inflatable one we talked about, that takes about 15 to 20 minutes longer, because we put that fluid reservoir in the pelvis, and that's done bluntly also in a different modalities. You can either go under the abdominal muscles, you can either go into the pelvis next to the bladder, or you can have it inside an ectopic location where it's beyond the backside of the bladder. And you can do that in a variety of ways without having to make a second incision. In very surgically complex patients, you do have to make a counter incision, but I would say that's pretty rare. Those would be the patients who have suffered from bladder cancer or something like that, and they've had a large pelvic incision to remove the bladder, and then we talked about that tube that comes out to the abdominal wall that's draining urine. You'd want to avoid that at all costs, so you typically do a direct visualization incision.
So one incision normally.
The vast majority are done in one incision, and that's done under the penis in a cosmetic way. Follows the line.
Okay, and then a couple of hours later, you're on your way home.
Yep, the catheter and a dressing. And I think the important thing to know about that is that the nursing staff take the time, and I also take the time to make very detailed instructions. And the catheter and the dressing are discontinued by the patient themselves, and before they go home, they have to feel comfortable doing that. Otherwise, they don't.
And when do they need to do that? I mean, a day or two after surgery, or?
So patients who have risk of bleeding, so say they're on an anticoagulation, I have them keep the dressing on for 2 days. The catheter always comes out the day after.
I see.
If they don't have a concern for bleeding, everything goes very smoothly. The dressing comes off the next day.
And then in terms of recovery, or when they're able to test it out, per se, I mean, what time period are we
So
looking at?
recovery is different for as I said, that there are 2 devices. Because you have less components, the recovery is a little bit more expedited. For everybody, regardless of the device, 1 week of light activity is really all you need. And then otherwise, the medications help you function and do your activities of daily living. For the quote-unquote recovery, where you're fully recovered for a malleable device, is generally about 4 weeks, as opposed to a inflatable device, which is about 6 weeks, because you have to heal around the pump that's placed in the scrotum, and you have to heal around the reservoir that's placed in the pelvis.
So for the malleable device, would you recommend that the person not work for at least a week?
No, and as I mentioned, it's light activity.
Light activity, so okay, so if they're just sitting at an office, they're fine.
Correct.
Okay, and then again, for the inflatable, what about then?
So the inflatable, because as I mentioned, you have a reservoir in the pelvis, much like hernia surgery, you have to avoid heavy lifting. So I ask patients to avoid heavy lifting for 4 weeks with that.
Okay.
And heavy lifting would be more than 10 to 20 pounds.
Okay. A few months ago, you performed a penile implant surgery. I think it was the first of its kind, or at least for a while, at Salinas Valley Health. Can you please tell us about that?
Yeah, nobody knew how to do it. Well, thankfully, I still knew how to do it, but yeah, that was actually a little scary for me, to be quite honest. I'm so used to being in that environment, and I mean, last year I did 27 of these, and then they told me they haven't done one in almost a decade or more than that.
Oh, wow. Okay.
And that's a long time not to do a surgery. And if you have somebody assisting you with that surgery that isn't familiar with it, it's really incumbent upon the physician to know how to do it. And that was an interesting experience, to say the least. But
a successful one.
Thankfully, I'm confident in that. So
Yes.
that worked out very well.
Okay, and how many have you performed since then?
So 2 so far.
2. Okay, so let's talk a little bit about that first surgery, and even the second surgery. How long does that surgery last?
So for the malleable implant, it takes about 45 minutes.
You mentioned that earlier, right?
Yeah, and about an hour for the inflatable device.
And again, the patient was released later that day, and everything
Yeah.
was fine. What did you, I guess when you had that post-op surgery meeting with the patient, I mean, what did that patient say, that first patient?
Well, the first one says, Dr. Griggs, you saved my marriage. And as I was really taken back because I had never heard that before. It's usually like, when can I use the device? That's usually the first question. But he was so really thankful for it. It kind of took me back, and I had to go home and tell my wife and everybody else. It just really filled me with so much joy when I heard that. And then when I had my second one done, I mean, if I remember correctly, his exact words is that I changed his life, and I've even told my brother about you.
Wow.
And I don't think that really pays more compliment than referring you to somebody else.
Well, you're giving them their life back, and obviously helping with their relationship and their self-esteem. I mean, that's really important. So congratulations to you and to those patients. And
Thank you.
And speaking of patients, I would like to introduce Mr. Jesse Hill. How are you, sir? Thank you for being here.
I'm doing great. How are you doing?
Very good, thank you. And we just heard a little bit about you. But I want to ask you a few questions. I mean, I guess, when did this problem, ED, start for you?
Well, it started back in 2000 for me. I mean, I think I was maybe like 30, in my 30s, and I didn't know, what was going on. And then I went to my doctor, and he explained to me, well, when you're diabetic, you got to take pills because you don't perform like you used to be. So I'll say, okay, let me try the pills. And the pills, I said, nah, this is not for me because you got to wait like an hour. And then I used to get headaches, and then, then your heart starts racing. And then for me, the pills didn't work. It was like you will get direction, but then it will go down again. So it was like still failure to me.
And I'm sure that was also expensive.
Yeah, very expensive. And it's like, like the relationship is not really there like you want it to be because you don't want to hurt the person's feelings. And they always tell you, oh, it's okay, maybe next time. But then you get tired of hearing that.
Sure. For your self-esteem is suffering. And
Very, very suffering.
on top of what's happening. So walk us through this. I mean, how did you hear about this type of surgery, and when did you get to that point where you thought, I need to do something about this?
Well, I went to go see my doctor, and he was telling me the same thing that every other doctor. Well, there's pills for, and there's nothing for diabetics. You're just gonna have to take pills. So then one day I was just like, let me just Google it. And then that's when I
Google.
see Google. And then basically it's just, I watched it on YouTube actually. And they were saying, yeah, you can get an implant. And I was like, really? And I was like, how long this been going? And they go, this has been around for like 10, 15 years. So then I was reading online, the first one was performed by a Russian doctor. So this is back in the 60s. And I'm like, wait a minute, where have I been? And then it was like,
Not in Russia.
and then I was like, okay, so I didn't think they did it in the US. So I said, when I looked online, there was a guy that said he got it done in India. And then I was reading his reviews and everything. And then there was a doctor say, well, you can get it done in Mexico for $5,000. So I'm saying, okay, maybe I'm gonna want to take a trip to Mexico. And then they said, you can do it for like $5,000. So I researched, and then they were saying, okay, am I really gonna do it? Then I said, let me just try to Google it in the United States. And I said, the closest one, and it brought up Salinas. And the first person I seen was his name. So I said, wait a minute.
Dr. Ryan Griggs.
Yeah, and I said, what's so funny about it? My doctor's downstairs, and he didn't tell me about the guy upstairs. And I was asking about
And this is in our prime care facility in Salinas.
Exactly.
Yeah,
Yes.
and I met that guy.
and I was like, why did he tell me about him upstairs? And he's supposed to be my diabetes doctor.
Well, he's watching now, and he's not going to make that mistake again.
So from there, when I went to see him, he tested me for colon and all that, did my colon and everything, and then I was asking him about it. And he was explaining to me about it. He said, oh, you really want to get it done? I could change your life. And I said, yes. I mean, I'm tired of suffering. So he walked me through it, and he did, like all the tests on me, and he said, okay, your prostate came back good, so when do you want to do it? So I said, I want to do it as soon as possible. So then he said, well, maybe we can get you in November. Well, actually it was December, but he said, well, I got the next one available in November. Do you want to do it? And I said, I'm on board.
Right before Christmas.
Right before Christmas.
Hey, before Thanksgiving.
And before Thanksgiving.
And then when he did that, I was happy. I was telling, my wife and everything about it. It's like, hey, I got this doctor that might change our lives. And she said, well, what does he do? And I was telling her about it, and she was excited. So then I explained to her how it worked. I said, I don't know how it really works, but he was telling me that it's going to change our lives, and that it did.
And I'm sorry, I have to ask, was it the malleable implant?
Yes.
Okay, that's okay.
He recommended that one because he's saying that, I'm not that old. I can kind of, work it myself. So I said, yeah, let me go with that one.
Okay.
Yeah.
So I have a couple of questions for you. What was the recovery like after surgery?
I didn't have no pain, nothing. That's why he was telling me you might have a little pain. He gave me some Tylenol. I didn't even take the Tylenol. I was like, I don't feel nothing. And I had to look down and make sure everything was there. And I was like, no, it's there, but I don't feel no pain.
That's a success story.
So I recommend people, don't worry about the pain. I mean, everybody's different. Well, for me, I got lucky because I didn't have no pain.
Right.
That's a key piece of information. Everybody's different.
Yeah, and before we started, you had mentioned that as a diabetic, you have some issues with your nerves, right? So that might be a reason why maybe you didn't feel much afterwards in terms of pain.
So it worked out great for me.
Yeah. Old saying in urology, nose, toes, hose. Basically here, down peripherally, you have difficulty with nerve endings in diabetes. So your member, for lack of a better term, your toes. You get numbness and tingling and decreased sensation, trouble orgasming, and things like that.
Okay. And what do you want to tell men out there who are suffering, again, people for whatever reason, either because of cancer or other issues, who are having the same issue that you were experiencing, who just are not sure about whether or not they want to call Dr. Griggs or even talk with their primary care physician about their issues?
Well, I recommend get it done because, anybody knows as a diabetic, the pain is there, the suffering there. I mean, if you're in a relationship, both of you guys are suffering because you're more worried about, making her happy, and she's more about not hurting your feelings, making you happy. And I recommend it, because it's a life changer. It'll bring back your youth. I mean, you'll never regret it once you get it done.
Okay.
Well, most patients, I have to say this, wish they had done it sooner.
No, I'm sure. I'm sure.
And I can agree with that.
And I want to go back to something that you said that caught my ear there, is that you were considering traveling to Mexico. You had read that the surgery could be done for $5,000.
Yes.
I mean, how serious were you about going to Mexico?
Well, I was very serious because I was like, look, either, I get it done or I never get it done because, like I said, going through this for almost 20-some years, suffering from this, you go through any extreme measurement to get it done. I mean, it's like taking a chance in anything. And I was willing to take that chance.
And that's a big chance. Dr. Griggs, I guess a follow-up question for you is, what do you want to tell men out there who may be considering traveling to Mexico or any other country for that matter to have a procedure like this or any other kind of surgery performed?
I mean, certainly I'm biased because I'm an American physician, but what I would say to that caveat is that there are great physicians in every country on this earth.
Of course.
Okay. He mentioned a surgeon in Russia, for example, in India, for example. I mean, there's a guy in Brazil that does way more than me, okay? But there's a patient trust factor, I think, that people overlook when they're trying to get a surgical procedure done outside because of a monetary discrepancy between the US and some other country. And the patient becomes blinded by that. Mm-hmm. Oh, this is a ticket price that I can afford, right? But is it with the right person? Right. And unfortunately, patients really don't have the access that physicians have to know, is this the right person to be doing this surgery? Right. And I mean, I see patients not involved with men's health that come in with a surgical incision that's the length of between my two fingers here just to take a kidney stone out, and that doesn't exist anymore. And so you see things like that are done, and that puts a little distrust, I would say, but I have to remember and take myself back. That's not everybody. And if that's something that the patient wants to do, I would guide my patient. Hey, I know this person here, or I can contact somebody who knows a guy there. And if that's really what you want to do, then I would support them and help them and be their shepherd, if you will.
And you also know their history, their medical history, right? So you can look at all the charts versus going to another country. They are only going to know what you provide them with, what information you provide them with.
That's right.
And then also, what about complications afterwards?
Oh, God.
Things to consider, right? I mean, we want to make sure people understand
nobody wants
this.
to talk about complications, right? But
if it's done in another country, what are you going to do? Are you going to go back 3 weeks later and have another procedure? I mean,
most commonly they come back here.
Right.
In my
Something
experience.
that you have to fix now.
And it's not always that easy.
Right. Just things that people should keep in mind, I think, and just have that conversation with your primary care physician or your urologist.
And sometimes that physician's not as helpful as I may be, or some other physician, and they don't really furnish the types of information that you would need for documentation, or it's in a different language and it's not translatable, or and then you're really stuck with, oh, I've got to figure out this picture by imaging, right? And I receive referrals from people who've had devices before, and if they don't have an operative report, they get imaged, because the number one rule in surgery is trust nobody. You have to be comfortable as a surgeon, and in order to do that, I need to know what you have in. Say a patient had an infection and part of the device was removed, but they say all the device was removed. Unless you have an op report saying that in plain sight, then an imaging study is done to make sure that everything is out. Because if not, things happen. We don't like that to happen.
We don't want that to happen. So the best thing is to be informed, really do your research, talk to your doctors, and maybe see a different physician if that's the case, if you feel like you're getting to a point where you're not getting the answers that you need, or the counseling, I suppose, that you need. Well, thank you so much, Mr. Hill,
You're welcome.
for sharing your information. I really appreciate you being here. Dr. Griggs, you will soon start hosting free community classes for men. These are going to be on a quarterly basis. They are called, and I love the title that you gave them, Not Just Another Mentality. Not
Capital
just
MEN.
another,
Yeah, that's right.
Yeah, not just another mentality. What will you be discussing in these quarterly meetings?
Well, first of all, I had to Google a lot myself because I had to make sure I wasn't treading on somebody else's shoes, right? And YouTube is the number two search engine above Google, by the way, which is pretty staggering. But so I was like Googling, and a couple of my colleagues actually have a podcast called the Man Up Pod. And I was like, oh, well, that's a really good play on words. And I was just trying to think of something that kind of rings true to everybody. And I think what we'll be talking about there is really all aspects of men's health, from lifestyle changes. How can I be more intimate with my partner? What things are out there to help me be intimate with my partner? What surgeries are available for erectile dysfunction, hormone replacement for lack of libido, surgical or medical management of urinary incontinence that's urge because you can't make it to the restroom, curvature of the penis. It's underreported, but something I really like to manage. It's called Peyronie's disease. Ejaculatory dysfunction. Do I get happy too quick, or do I not get happy at all? How can we manage that? What medications are available, counseling, and things like that. And I think that's one important facet that we didn't focus on is counseling. And I said one of the hats I have is as a counselor. I'm not just your doctor, not a parent, but a counselor and a partner in their health. And if I'm not able to adequately address a patient's concern about their quality of life issue, then I employ other professionals, mainly sexual therapists, because it's been shown that psychological therapy plus medications is more beneficial in ejaculatory dysfunction, much like other disorders like depression, anxiety. You can take a pill, but if you have therapy plus a pill, it works better.
Okay. Well, this is great information, and I congratulate you on getting these classes started.
Thank you.
And they are free, as I mentioned. Now, can partners, spouses, or just partners, can they join, or is it just?
100%. I actually advocate that.
Great, that's good. Okay, well, that's good to know. The first community class takes place April 19th from 1 to 1:30 p.m. at the Diabetes and Education Center, located in our Prime Care building here in Salinas. The address is 355 Abbott Street, Suite 200, so on the second floor. The other classes will take place at the same time on the following dates: June 28th, September 27th, and December 27th. These classes are free. You may bring your partner or your spouse. As Dr. Griggs just mentioned, you must RSVP though, and the reason for that is that space is limited, so that's very important. To RSVP, please call the number there on your screen. The phone number is 831-422-4500. 422-4500, and those classes will all be facilitated by Dr. Ryan Griggs. Any final words, advice for men out there who have either urinary incontinence issues or erectile dysfunction issues?
Well, I won't forget about your question, I promise, but I was just thinking to myself is that I really wanted to say a warm thank you to you, Mr. Hill.
Well, thank you.
And you took time out of your day to really spread your story to help me, and I'm immensely appreciative of that. And I also wanted to thank you for allowing me to be your physician and surgeon and trusting me with your body, and I'm here to guide you through the rest of the way, and I just wholeheartedly thank you so much. Appreciate you.
I want to thank you too. I mean, it's a life changer for me. Because like I said, I was suffering from this for years, and I didn't know there was a solution for it. I mean, all I was told was take a pill, but now I know there's another
Good
solution.
thing you met me, right?
Yeah. Thank you.
You're welcome.
You may be joining those classes soon and being his co-partner there.
Everybody needs a co-pilot, right?
I'm just producing here. Don't mind me. I'm just
I like it. I like it. And then to your question, I would say don't suffer in silence. I've said this before. If you can't be intimate with your partner, I'm a firm believer in sex and being intimate with your partner is a huge facet of your quality of life. And I always market myself as a quality of life surgeon and physician. And you don't have to accept that unless you have to. A lot of people don't know the options. I'm here to educate them, tell them what the options are, and then the patient and I, through shared decision making, choose a treatment that's best for them. And I would say don't hang up the apron until you absolutely need to.
You are their partner in this journey. All right, well, if you want to schedule an appointment with Dr. Ryan Griggs, please call the number there on your screen. It's 831-422-4500. This is at Salinas Valley Health Urology. The number, once again, 422-4500. Dr. Griggs, we really appreciate you taking time out of your busy schedule. I know you had some surgeries today.
Yeah.
So
Thank you for having me.
Of course, and thank you for being here. And
Yeah.
to you, Mr. Hill, thank you again for, can't thank you enough. And we're so happy that you're doing well and that your wife is happy and that everything's going well. And we appreciate
Happy life, right?
Thank you.
you helping, yes, to share the great news with the community. This video will remain right here on this Facebook page, so please like and share it. Please like and share it if you're on social media. We also invite you to follow us on our other social media sites, which are YouTube, Twitter, Instagram, and LinkedIn. I'm Claudia Otero. We'll see you next time.